Hello and welcome to the Supportive Care Services Virtual Lunch and Learn series. My name is Vonsell Hunter with the Ironwood Cancer and Research Center's Marketing Department. The Supportive Care Services Department has created a series of virtual lunch and learn videos to help you be successful when navigating your cancer journey. Our Supportive Care Services Department is here to help you get actively involved in your healing process. For more information about the Supportive Care Services Department, please email socialwork@ironwoodcrc.com.
Hello, my name is Joseph DeComo, and I am a breast surgical oncologist at Ironwood Cancer and Research Centers. I have offices in Avondale and Sun City. Today, we're going to be talking about male breast cancer. So male breast cancer is relatively rare. Only 0.5% to 1% of all breast cancers occur in men, and it's about 2,500 men diagnosed every year in the United States. Stage for stage, the outcome in men with breast cancer is similar to those in women with the disease. Men generally present at an older age than women, and they may present at a later stage as well. Breast cancer in men is most commonly invasive ductal carcinoma, which is the same as females. It is usually estrogen receptor and progesterone receptor positive, so that would make an ER/PR positive tumor, and generally HER2 negative. When a patient presents with a concern regarding their breasts, we start with a breast and axillary examination. There's three things that could cause a breast mass in men generally. One of them would be gynecomastia, which is proliferation of breast tissue. Usually on physical exam, this would be concentric and tissue that's generally right beneath the areola. It has a rubbery consistency, and during the acute phases while this is growing, it can be very tender. Pseudogynecomastia isn't breast tissue that's growing. It's generally when increased adipose tissue is placed on the breast. So it's basically fat buildup. It consists of mainly fatty tissue, and it doesn't have that rubbery consistency that you see in gynecomastia. Cancers and other concerning lesions are typically irregular, hard, and non-tender to palpation. They can also be growing in eccentric patterns, and these can be fixed, meaning that they don't move around when you touch them. Some of the causes for breast enlargement could be due to hormonal factors. So generally, if we're not concerned about a mass in the area, we will test for certain hormones. Routine mammograms and ultrasounds, which may be beneficial in women as a screening modality, aren't indicated in men. However, we sometimes order these to help us establish a diagnosis if the clinical exam is not sufficient. For suspected breast cancers, the National Comprehensive Cancer Network, also known as the NCCN guidelines, recommend imaging for men with breast cancer with a mammogram and ultrasound. If something concerning is identified, a core biopsy will be performed, and that is where a piece of tissue is obtained for further analysis. All men that come back positive for breast cancer should be considered for genetic counseling and testing. For men with BRCA mutations, screening intervals are unknown, unlike for females, where a BRCA mutation would usually lead to earlier screening and increased frequency of screening. Prostate cancer has been shown to have an association with BRCA mutations. Per NCCN guidelines, men should be trained for breast self-examinations and have provider examinations starting at age 35. Basically, what we recommend is just breast awareness. If anything is abnormal, or if you notice a change in your own body, bring that to the attention of your physician. Some of the genetics that we see in men with breast cancer include BRCA2, BRCA1, P10. BRCA2 is primarily an autosomal dominant gene mutation involved in breast cancer. It's also associated with prostate and pancreatic cancer, and to a lesser extent, melanoma. BRCA1 and P10, these are both tumor suppressor genes, and there's also the PLB2 and CHEK2 and CYP17 mutations, which are also involved with an increased risk of breast cancer. The incidence of BRCA gene mutations in men is somewhere between 0 and 4% for BRCA1 mutations and 4 to 16% for BRCA2. The incidence of these mutations is 5% to 10% in women. In women, the mutations may confer a 45 to 65% risk of breast cancer by age 70. In men, even if they have the BRCA mutation, the risk of breast cancer is substantially lower, at 1.2% for BRCA1 mutations and about 7% for BRCA2 mutations. There are some other testing that's performed in men with breast cancer after the tumor is removed via surgery. Genomic tests such as the Oncotype DX21 gene assay may be performed. These are often performed in women after they've had surgery to test to see if chemotherapy will be of benefit in the treatment of that cancer. And it shows that this holds true for men as well. And men have similar recurrence scores as women, so the risk of recurrence is generally about the same between them. So if someone's diagnosed with male breast cancer, our operative treatment is a little different than that of females. A total simple mastectomy is the procedure used most likely. Sentinel lymph nodes are also obtained during this time if no clinical nodes are noted at the time of evaluation or on imaging. Basically, during the time of surgery, the entire breast tissue is removed. Before that, the breast is injected with 2 tracers that help us find the lymph nodes which drain that breast. That way, those lymph nodes can be found during the surgery and sampled. In females, breast conservation therapy can often be used. There have been some tests on breast conservation therapy in men, and it appears to be safe. However, it's a little controversial at this time, and more studies are needed. Some adjuvant treatment in addition to surgery include endocrine therapy and chemotherapy. So endocrine therapy, usually adjuvant tamoxifen rather than an aromatase inhibitor, is recommended. If tamoxifen is contraindicated due to a history of blood clots, then the use of an aromatase inhibitor with a gonadotropin releasing analog is recommended. Use of an aromatase inhibitor alone is not sufficient. So basically, in those tumors that are ER/PR positive, which would benefit from endocrine therapy, these are cancers that are fueled by estrogen, we basically have to use one of these estrogen blocking modalities. Neoadjuvant chemotherapy, which means chemotherapy before surgery. Neoadjuvant before, adjuvant after, is sometimes used. Basically, we use neoadjuvant chemotherapy in stages, in cases where we can downstage the disease. Basically, this would be T4 cancers, which are larger cancers, cancers which we know have metastasized to the lymph nodes, and also patients with cancers that are at higher risk. For example, cancers that do not show any hormone positivity, that is estrogen, progesterone, or HER2, or those that are HER2 positive. Basically, you can use neoadjuvant therapy before surgery to possibly downstage this disease. Long-term follow-up for men with breast cancer, basically clinical physical exams are used 1 to 4 times a year for 5 years, and then annually after that. Different surgeons have different preferences. I personally like to see my patients immediately post-operatively, then at 3 months, 6 months, 12 months, and then yearly after that. Mammograms are not necessary during this time. Just like in females who have had a mastectomy, a physical exam is what will normally be done. If you feel anything abnormal, then that can be further worked up. Sometimes you can use a mammogram in men as well on the contralateral breast if you're concerned about any gynecomastia or anything else that has changed that needs to be evaluated. And that's pretty much it. So male breast cancer, definitely a rare entity, but it does occur. Any mass in a male should be evaluated. Any new growth, any change in your breast tissue should be evaluated by a physician. Thank you.
Thank you for joining us for our virtual Lunch and Learn presentation. We hope you enjoyed this session. There will be a replay of this Lunch and Learn on the Ironwood YouTube and social media channels. For more information regarding our supportive care services classes and events, please email us at wellness@ironwoodcrc.com. Thank you for spending time with us today.